Welcome, everyone. Thank you for attending our special closer look at COVID-19. This is a really important opportunity to get the most up-to-the-minute ideas about how we tackle COVID in the area of the biggest vaccination program this country has ever seen. We're incredibly grateful to our august group of speakers today. The reason I have the space background is essentially because the sky is no longer the limit when it comes to preventing, diagnosing, and treating COVID-19. Ideally, of course, we want to prevent it, but we're really very pleased to have Robert Schooley, who we affectionately know as Chip Schooley. He's really been a stalwart champion for developing our programs, including Return to Learn for our patients, has run global health initiatives that included eradicating HIV to the extent that anyone can, and really applying all that he learned as the former division chief for infectious diseases to this pandemic very successfully. Is on TV every time I turn it on, and is a local, rather famous person, but who's had not just national but international impact because of his work. He is currently the Vice Chair of Academic Affairs. He's a Senior Director of International Initiatives and co-director for the Center for Innovative Phage Applications and Therapeutics at the University of California, San Diego. So with us, and I think, it's important to say he's a physician's physician. Chip Schooley is the one you turn to when the going gets tough and you really want to help a patient. When it came to the phage therapy, I would see him in the ICU every single day. I'm a hematologist, look after some pretty sick patients. Chip is always there. Similarly, Davey Smith, who's the current chief of the Division of Infectious Diseases and Global Health, has been incredibly effective in terms of how do we intercede when people do get COVID-19? How do we predict the severity? How do we intervene? He's also on TV just about every morning when I'm watching the early morning news. So he's really been an important guide for the community, not just academically, but really practically. How do we intercede when people have COVID-19? And finally, Sheldon Morris, also in the Division of Infectious Diseases, has really applied his understanding of how you predict and prevent pandemics from his MPH at Harvard School of Public Health to understand how we prevent propagation of this virus in immunocompromised patients and other groups, and looking at it more from a public health angle. So I'd like to introduce Dr. Schooley because he will actually be moderating the question session. We will have a couple of talks and finish those talks within about an hour. Really want to get in depth into COVID because we have three of the leaders in the field right here. And then Dr. Schooley will handle the questions through the Q&A, and then I'll come back to wrap it up. So over to you, Dr. Schooley.
Thanks so much, Dr. Jameson. It's a delight to be here today, and I appreciate very much the opportunity to be here with Dr. Morris and Dr. Smith. What I'm going to do today is spend a little bit of time just introducing COVID from the perspective of some of the lessons we've learned over the last year. It's really been like drinking from a fire hose, watching our understanding of this disease move as rapidly as it has, and our challenges that we've had in getting from where we are now to where we need to be are ones that have been brought to our attention by paying attention over the last year. So I'm just going to talk a little bit about some of the high points and low points, and then we'll have more detailed discussions about therapeutics and prevention from Drs. Smith and Morris. It's hard to believe that the epidemic is really just a little over a year and a quarter old. It seems as if we have been dealing with this forever. At least that's the way my dog feels about it. And it really wasn't that long ago that we were first seeing these images of a food market in China, in Wuhan, located kind of halfway between Hong Kong and Beijing, where we were beginning to hear about a respiratory disease that was emerging around this wet market in December or so of 2019. In retrospect, the virus that we now know as SARS-CoV-2 had probably gotten into the human population a couple of months earlier than that. And as with most new epidemics, it takes a while to recognize that something is beginning to move about. Over the course of the month after we heard about it, the virus spread rapidly throughout China. And by the end of that month, there were 20,000 cases in China. Many of us thought, boy, that is an incredible number of cases so rapidly when you think about the fact that SARS, its predecessor, peaked at 8,000 cases back in 2003. If you look at what the virus has been able to do since that time, you can see now that there are 137 million cases that we have counted globally, but likely many more infections than that. It has accounted for almost 3 million deaths globally, and over 500,000 Americans have died of this disease. The virus has run a series of humps up and down over the course of the last year in the US, several peaks, each one worse than the one before. We came down a terrible peak over the course of the last 2 months and are now down at what we hope is a plateau, but we're concerned may be the beginning of another rise as some of the variants that I'll talk about in a minute begin to circulate more rapidly. Now, let me talk about the 4 or 5 lessons that we learned over the course of the last year in dealing with this. Lesson number 1 has to do with diagnosis. It was really important when this virus began to spread to know who had it, both from the standpoint of epidemiology and from the standpoint of prevention. Within a couple of weeks of the sequence of this virus being known, very highly accurate PCR and other tests were available that could detect with a high degree of accuracy people who were infected with the virus. In the US, we stumbled in multiple ways in terms of getting this testing available to manage the epidemic. The FDA initially essentially made the only available testing in the US from the CDC by not allowing academic laboratories to use their skills and ingenuity to be able to support diagnosis of patients as they came to our hospitals, while the CDC spent 6 weeks trying to develop its own test. Dr. Smith and others on this campus had very highly accurate tests, but they were prevented from using them because of this CLIA model in which clinical pathology laboratories have essentially cornered the market in terms of testing in clinical settings. And in this global pandemic, that tension cost us several more months. And then finally, there was a gross misunderstanding and lack of understanding about how many tests would be available. The CDC initially thought they'd need to be able to do a couple hundred tests a week. They would be able to fly into some place when when a patient was potentially diagnosed and test that patient. And there was no effort and no understanding. We'd have to ramp up to be able to do millions of tests a week to be able to stay ahead of this epidemic. Right now, we're at a place where we can, testing is widely available, and we have multiple different formats which have been highly successful. Where we have failed, however, is to move what was a medical model into a commodities model. There's no reason for a test that we need to have available to support the population being as expensive as it is now, given the true cost of doing these tests. Lesson number 2 is we learned a lot about the pathogenesis of this disease early on. And what we were learning about the pathogenesis should have told us how to approach prevention in a much more rapid fashion. SARS-CoV, the predecessor we dealt with 18 years ago, and MERS that came on in between then and now, both got to maximal infectivity after people had developed symptoms, which made it very possible to isolate people when they showed up in the hospital and prevent ongoing spread. This virus turns off the innate immune response early on. I'll show you, this is just to focus on the left panel. You can see that when you look at interferon induction, after you infect lung cells, you can see that in gray when there is no virus present, or in red when SARS-CoV-2 is present, there is no induction of any of the innate immune response markers. On the other hand, SARS-CoV, the original SARS virus, induces a potent immune response with interferons and other cytokines. And this signals the host that they're sick and causes symptoms, and also contains the virus. The SARS-CoV-2 in red grows 3.5 times as rapidly in lung explants as SARS-CoV, and grows in people who've been infected to very high titers in the lungs, to the point that people, even before they're symptomatic, are shedding large amounts of virus. Lesson number two was, part two, is that despite the fact that we knew all this, we continued to try to use outmoded approaches to counsel people about spread. We got fixated on things like fomites, which will play a role in influenza. This is not influenza. And we kept trying to call this a virus that was spread by droplets, not by small aerosols. Now, why is this important? Well, the public health model that's used in infection control settings has developed this dichotomy over the years that classifies pathogens into those that are spread by droplets. And these are pathogens that putatively are spread in these large blue bubbles that fall to the ground within 6 feet, and aerosol pathogens, ones that can spread much further. Unfortunately, the classifications of things as aerosols has been extremely conservative. Measles is known to be an aerosol, and for a long time, no one wanted to admit that SARS-CoV-2 is an aerosol. And what that led to was advice about prevention of transmission, both in hospital settings and in the community, that were based on the fact that we just needed to protect people who were closer than 6 feet. When in fact, even within 6 feet, most of the virus is spread from one person's lungs to another as these viral particles descend deeply into the lungs and cause disease. That has a lot of impact in terms of how we live together and what we've done. When people exercise, they expel more air and more virus. And we know as well that in gyms, the virus can spread from pre-symptomatic people. We know that there can be droplets that spray when people do exercise, sing and yell, play instruments. But we also know that at the same time, these aerosols are spreading much further. We know that because these aerosols disperse in the community, of course, they're in space, of course, you're going to see more people get infected if they're close to someone, but that doesn't mean they're being infected because of the droplets. Aerosols have the same characteristics. And finally, people have said for a long time, no one has isolated infectious SARS-CoV-2 from the air. In fact, several groups have done that now, and we know that this is quite easily done if you use the right techniques. And finally, there have been multiple different episodes of long-range aerosol spread, including church choirs and other settings that make it impossible to claim that all spread is droplet-induced. Lesson number three is that it was going to be very important to develop a safe and effective vaccine. And here, I have to say, we deserve close to an A for this. The scientific community was left to do this, and the scientific community did very well. And much of what happened was built on what we learned from the vaccine science and human immunology that was driven by the effort to develop an AIDS vaccine over the last 30 years. We were smart because we placed bets that some vaccines would work, and we pre-purchased them before they'd even been shown to be effective while the testing was going on, so that if the vaccines turned to be effective, we could get them out to the population. And we focused on what we learned very quickly about how the virus gets from cell to cell. Spike proteins on the surface are the key mechanism by which the virus attaches to cells that it binds, and were the key targets in vaccine development. All of this science has now gotten us to several different types of vaccines. In the US, we have messenger RNA vaccines that are available that are extremely effective, as I'll show you in just a minute. There are also viral vector vaccines in which we use, in most cases, crippled adenovirus to be able to present viral antigens to people that need vaccination. And there are other vaccine approaches using protein subunits, inactivated virus, more classical approaches that are also under development. But the vaccines that have been developed are extremely effective. This is these are data from the phase 3 study of the Moderna vaccine. And what you can see is that in blue, the people who received the placebo continued to be infected at the same rate, but within about 12 days of getting vaccinated, those who received the actual vaccine very quickly almost ceased having infection and virtually shut off any severe disease. So these vaccines are extremely effective. Because we pre-purchased them, we were able to get vaccines out around the country. The darker the state, the more successful we are. And you can see California, some parts of California, the Bay Area and San Diego have done quite well. Other parts of California have lagged. And we are not one of the leading states in terms of vaccine deployment. But in places where vaccines have been deployed, and as we've done it, you can see that as more and more people are vaccinated, the rate of rise of new cases is beginning to blunt. It's clear we're headed in the right direction with these with these coronavirus vaccines. Another important aspect was that we took multiple shots on goal. And that was important because we assumed that not every approach we took would go without a hiccup. And by having different contingency plans, we could react quickly when we began to see issues we needed to take a closer look at. Recently, as you know, there have been concerns that the adenovirus vaccines may be associated with a very unusual type of a blood clot that occurs in the cavernous sinus just behind the eyes. It's seen extremely rarely, 1 in a million people, a very rare event that wouldn't be seen in vaccine trials that only are undertaken in 20 or 30,000 people. It's also been seen in the other vaccine that's made with adenovirus, but very rarely seen in people who receive this mRNA vaccine. This has led to a pause in the use of the adenovirus-based vaccine in the US while we look at more carefully at the data. But because we have multiple alternatives, it allows us to keep vaccinating to try to push things down. Another lesson we learned is that this virus, like other RNA viruses, will diversify, and we developed surveillance plans and contingencies for how to deal with this. The variants we worry most about now are the so-called British variant. This one is one that is able to spread about 60% more effectively than the variants we had for the first 8 months of the epidemic. And then variants that have been called the South African and Brazilian strain that are very similar. They're able to spread more rapidly, but in addition, they have a key mutation that makes them less susceptible to some of the therapies that Dr. Smith will be talking about, and less susceptible to some of the vaccines that are marginal, but still highly susceptible to the mRNA vaccines. When these variants that are able to be transmitted more rapidly hit the population, this shows what happened in the UK when the British variant arrived. You can see they very quickly overwhelm what was present in the past and become the predominant strain. This British strain now accounts for about 50% of the viral strains in the US. This shows the British variant, the Brazilian variant, and the South African variant, again, present in virtually every state in the country and growing rapidly. And the final lesson that I think we learned from this disease is that we allowed the virus to divide us rather than to unite us. We learned a lot scientifically, and we needed to take what we learned scientifically and use that to develop a common purpose to end this epidemic. We're at a point right now that we have vaccines that we can take to the world. And it's important for us not just to unify in the US about how to approach this disease, but to unite around the world. Because if we allow this virus to replicate elsewhere, we're going to be allowing people who could be saved continue to die from this disease. And we're going to allow the virus to continue to replicate, continue to diversify, and ultimately set ourselves up for wave after wave of this disease. So to close, I'd just like to say that we're all in this together. And the things that I think we should learn is that science matters, preparation and competence matters, and it's important to be transparent and honest. We're all in this together. So thank you very much. And what I want to do right now is turn the stage over to my colleague, Dr. Davey Smith, who is going to talk in more detail about some of the therapeutic interventions that have been developed in parallel with these very successful vaccines. Dr. Smith.
Thanks, Chip. Thanks, everybody, for showing up. So today I'm going to talk a little bit about our antiviral progress, so treatments to treat the virus during the early stages. Just to point out, there's been a huge scientific effort both on the vaccine side that Chip talked about, but also on our treatment side. There's over 590 drugs in development that people are disclosed. There's 400 trials being reviewed by the FDA for COVID. There have been 9 COVID-19 treatments that currently have authorized emergency use, and then 1 that has been approved by the FDA for treatment. And I'm going to focus on the antiviral part, but let's go through the natural history just real quickly. So starts off with somebody being exposed to the virus. Everybody who's been exposed and who will eventually be infected they all start off with no symptoms, but most people go on to progress to mild symptoms, some progress to moderate symptoms, and then some even progress to severe or very life-threatening disease. At the beginning, it's all about the virus. The viral load goes up and then it goes down. So if we're going to target the early stages of COVID-19, we need to use antivirals. Later in the process, there's something about the virus that triggers inflammation, and that is when the mild disease changes to moderate to severe disease. And in that setting, we'd want to use immune modulators. Also in the later stages of the disease, people can become hypercoagulable. They can develop blood clots, oftentimes related to inflammation. And in that setting, perhaps anticoagulants are being used there. And all of these are being tested for treatment at these various stages. But it's very important to know what stage somebody's in to know what treatment to give them. And today I'm going to talk about stopping early COVID-19. So it's all going to be about these antivirals. So I'm going to give a little bit of virology life cycle and just kind of walk through some things. But here's the virus, and it has these little spike proteins. It uses those spike proteins to engage a human receptor to get into the cell. Perhaps you could use fusion inhibitors to stop that. This receptor is called the ACE2 receptor, and perhaps we could block that. There's also a protease, a protein that is needed, a protease that's needed in humans. That the virus co-opts for its own purpose, and perhaps we can inhibit that protease, and that would stop the virus from getting into the cell. There's also a thing called passive immunization, which I'll talk a lot about in a second, but perhaps we can repurpose some processes that we learned a long time ago about that. There's also immune modulators. So we have immune system responses that are antiviral responses, and perhaps we can use some of those or increase those immune modulation to stop the virus. Once the virus gets in, it makes copies of itself through an enzyme that it has called RNA polymerase. Maybe we can make inhibitors specifically for that protein. The virus also gets into this little endosome over here, and perhaps we can lock it in by acidifying that endosome. So all these are different targets that people are looking at. One of the big ones that was talked about first were the acidification of these endosomes. And that's exactly what hydroxychloroquine and azithromycin were supposed to do. And there were some trials, including one that I was trying to get off the ground that was trying to look at that, see if it worked. And the reason we wanted to know was that if it didn't work, we wanted to stop having people use it. And if it did work, we'd hope to use it. But politics got in the way, something that Chip sort of mentioned about dividing us. And we were never able to figure out if it would work for early COVID. So let's go look at some other things. One would be passive immunization. Well, a little bit of history lesson here. The first Nobel Prize in 1901 was for passive immunization. And what scientists did was they took diphtheria, which is a bacteria and it has a toxin, and they grew it up in the laboratory, and then they injected that toxin, killed toxin into a horse. And that horse made an immune response, an antibody or an antitoxin, and what it was called. And then they took the blood out of the horse, they concentrated the plasma to make these antitoxin-rich sera, and they used it to treat kids who had diphtheria as a passive immunization, and saved hundreds of thousands of kids' lives. So can we do something similar with COVID-19? Well, we can have somebody who got COVID, but they did well, and they made antibodies, and we could take blood from them through a process called apheresis and plasma, and this is what we call convalescent plasma, because this patient has convalesced, but we're going to take those antibodies that she made, and then we can give it to somebody else who's really sick and not doing so well with COVID-19. That's the goal. And there was a recent paper in January of this year showing that in convalescent plasma, if it's used within 72 hours and the person is older coming into the hospital, and oftentimes if they have comorbidities such as obesity or diabetes, or kidney disease, then convalescent plasma did improve their illness. So here on the y-axis is proportion of free disease. And those people who got convalescent plasma did a little better than people who got placebo. Unfortunately, there's been other studies that have come out since then, including multi-center studies of convalescent plasma in hospitalized patients that have been stopped because they've shown no efficacy. And this is just one that was recently reported at a conference last month. So there's another way to possibly do passive immunization using new tools that were also made popular or honed during the HIV research time, as Chip talked about. And one of these is called monoclonal antibodies. And how it works is that somebody who caught the virus makes antibodies, and they make a whole bunch of different kinds. And perhaps there's one that's really, really good. And we can pluck that antibody out and we can put it into a cell, and that allows it to be expanded. And then we can make lots and lots and lots of that one antibody. So mono being one, clone being clone. So we have one clone, monoclonal, and turn it into a treatment. And sometimes we can have more than one monoclonal antibody, which we call a cocktail, but then we can use it to treat other people with the virus. So this would be the goal here. And there's like 25 and maybe even more companies now out there making these monoclonal antibodies as treatment for COVID. And maybe you've seen some in the news. So here's a cocktail of monoclonal antibodies from Regeneron. And here in this study, let's just look at this graph one moment. So on the y-axis is the amount of virus that somebody has in their nose. On the x-axis is the number of days after they come in. And some people were given a placebo, and then the other people were given different doses of this cocktail, this Regeneron cocktail. And you can see that these lines start to diverge, that the people who got the placebo overall continue to have higher viral loads than either one of the groups that got the Regeneron monoclonal cocktail. And this meant that they got an emergency use authorization from the FDA. Also, President Trump got this exact cocktail when he got COVID. Another monoclonal antibody called bamlanivimab, made by Eli Lilly, was also tested. And here I'm going to focus on symptoms. On the y-axis is how many symptoms somebody has, and on the x-axis is how many days after they were starting to get the therapy. Some people got placebo, they're in the red line, and some people got the drug here in the blue line. And you can see that they diverge. So the people who got placebo had more symptoms than people who got bamlanivimab. This drug also got an emergency use authorization and is now being used for high-risk people who have COVID. The same drug, bamlanivimab, was used in a prevention study given to people in the nursing homes. I don't know if anybody remembers, but back this time last year, there were lots of people who were dying from COVID-19 in nursing homes because it basically spread like wildfire. So Lilly and other research groups came together and said, okay, let's give people who are in nursing homes this drug and see if it prevents them from getting infected. And sure enough, people who got bamlanivimab got infected less than the people who got placebo. Y-axis is the proportion of people who got the infection. And this is just to show similar data about the viral load. Just you can look at this axis on this figure here. This is the change in viral load. This is the study day after somebody started the therapy. This is the placebo. And you can see that the people who got bamlanivimab plus another monoclonal antibody called atezolizumab that they put together in a cocktail, they had lower viral loads than people who got placebo. So, okay, viral loads, symptoms, getting infected. What we really want to know is, can we keep people out of the hospital and can we keep people from dying? So here is bamlanivimab and atezolizumab, and over here is hospitalizations by any cause. People who got placebo in these studies had a 7% rate of hospitalization versus people who got the placebo only had a 2% hospitalization. And then when you look at deaths, the people who got placebo, 10 of them died in that study versus nobody who got the monoclonal cocktail died in that study. Both of this got an emergency use authorization, this cocktail combination, and the National Institutes of Health guidelines said this should be used for people who have high risk criteria for causing problems with COVID-19 should be eligible and should get this drug. So just a quick recap on monoclonal antibodies. At present, it's only for people who have high-risk conditions with early COVID-19. It is not for people who are already hospitalized. There are now multiple studies looking at monoclonal antibodies for people who are hospitalized, and they either show no benefit whatsoever or perhaps even worse. So right now it is only for people who high risk, who have start of symptoms. So they don't need oxygen. There's no increase in their usual oxygen needs. And the other good news is there's going to be future routes given for these monoclonal antibodies. Right now, it's kind of a pain because we have to do it as an intravenous infusion, but companies are coming up with intramuscular, so like an injection, like you could think of like a vaccine, or sub-Q, like a diabetic shot, or even inhaled agents. And we're hoping that this really helps get these drugs out to more people who could use them. But other big notes are that EUA, emergency use authorization, does not mean full approval, and the FDA has explicitly encouraged more research before they can grant that full approval. So I want to talk a little bit about variants because it's a lot in the news, and Chip talked about it at the beginning. But among RNA viruses, which is what a coronavirus is, it has a modest mutation rate. It actually has a little bit of a proofreading mechanism, so it doesn't mutate as much as others, but it does. And I'm going to go walk through one example of why that's important. So there's this mutation called D614G, and it's in the spike protein of the virus. And you're like, what in the world does that mean? It's been shown to increase infectivity, and it's been shown to increase transmissibility in animal models. But how us virologists talk is we think of a protein, let's say a spike protein is a bunch of just amino acids, and each one of those amino acids has a letter. And in this case, it's aspartic acid is the D, and the G is glycine. And let's say we just have a group of letters that spell out Dr. Davey Smith. And at the 614th position, there is a D that in the new virus, the new mutant that has happened, it changes to a G. So that's what we would call D614G. And that's exactly what COVID-19 SARS-CoV-2 did. It changed this one amino acid to increase its infectivity and to increase the amount of virus it produces when it infects somebody. Why this is going on is because the virus was originally well adapted to bats, and it probably liked having that aspartic acid at the 614th position a lot. But now that it's in humans, it doesn't interact as well with our receptors so much. So it changed it to a glycine, and then it allowed it to grow better. And we're expecting that to be the case with all these variants that we see. And in fact, here, this shows that throughout the world, back in February, all the viruses basically had a D at that 614 position, but now they all have a 614G. Why does that matter? Well, for treatment, not only could it be more infectious and perhaps more deadly, but for treatment, these antibody cocktails might not work as well. So here is B117, which was first found in the UK. Then there's this D614G that I talked about. And there's this other one called B1351, which was first found in South Africa. And these are the different monoclonal cocktails that we are currently studying for treatment. And they all seem to work for each of these variants. This is the amount of virus that's neutralized by these variants, by these monoclonal antibodies. But this variant, 351, completely knocks out these Lilly, bamlanivimab, and Otesi compounds. So as these variants become more prevalent in the population, our utility, our usefulness of some of these monoclonal antibodies isn't going to work so much anymore. We have to keep up with that. And just to show a big complicated table is that there are tons of variants that people are watching, and we're looking very closely at how well they still work for these variants, and if any of these variants become resistant to the therapies that we have. And then I'm going to talk a little bit about cows because I like the picture. So there's a nice company that have figured out how to transplant a human immune system in a cow. The company's called SAB. And they then have these cows that make lots and lots of blood and lots of plasma, and they vaccinate these cows with the coronavirus vaccines, the spike proteins, and then the cows make these antibodies, lots and lots of antibodies, and lots of different kind of antibodies. So rather than monoclonal, it's what we call polyclonal, so different types of antibodies. And then they take out the blood plasma from these cows, they concentrate it, and then they use that sort of as a super concentrated convalescent plasma. And since it's a human immune system in the cows, there's less reactivity to the plasma. So those are trials going on right now using that compound. So another one that we can tackle is this RNA polymerase. So how to stop this viral protein from replicating the virus. And there's a new drug called, well, it's not that much new, it's kind of repurposed, but it's EIDD, and it was made by Ridgeback, which is then bought by Merck, and it stops that enzyme. But it has activity against other RNA viruses, such as Ebola and flu and other coronaviruses. And how it does it is it causes that enzyme to just go crazy and cause lots of mutations, which sounds horrible, but actually increases the mutations so much that the virus just can't survive. It can't be good enough to make good copies of itself. And here is the y-axis is how much virus is being made. On the x-axis is how much concentration of the drug. And you can see there's a big drop. If you get enough drug in, the virus just messes up too much and it can't make good copies of itself. And then they tested it in ferrets. So cute little ferrets can get infected with coronavirus. They give it multiple doses at multiple different times. And these are just looking at the different ways. But in each of the cases, here's the black line is a placebo, but each of these other colors, when the ferrets got the drug at different time points, it was all able to stop the viral replication. And this drug is currently in trials in humans to see if it can stop early COVID. And here is recent data showing that in 175 people on day 3 after starting the drug, there really wasn't much difference between the people who got placebo here in purple and the people who got the active drug yet. But then at day 5, the people who had placebo still had drug that they could detect, but nobody in the who got the drug themselves versus the placebo could be detected. So another one is this protease inhibitor. So we have these things called serine proteases, and the virus wants to use one of those. And maybe if we can just block it for a little bit of time, we can stop the virus from going. And one of these drugs, or the protease inhibitors, is called Camostat. And we've known about the drug for a long time because in Japan, they use it for pancreatitis, and they've been doing it since 1985. We don't use it here, but it has been used and has a long safe drug to use. But we know that other coronaviruses use that same protease. And here is MERS, SARS-1 or senior, and SARS-2 or junior, versus this other virus, VSV, that doesn't use that protease. But if you use that inhibitor, you can see that it knocks down the viral replication for all these coronaviruses, including SARS-2. And this is done in the lab. So maybe it'll work in humans, and that drug is also being tested. And then another immune modulator that maybe many people have heard about is interferon. We've used it for many different viral infections along the way, like hepatitis B and hepatitis C. So perhaps we can use it here for COVID-2. And here are both 2 forms of it, interferon alpha and interferon beta. It's grown in a Petri dish in the lab. Here's the amount of virus that's grown. And here's the doses over time. These are the doses that are given. And you can see that each of those at increasing doses drive down the amount of virus that we can see in the Petri dish. And then when we tested in humans, in terms of actually inhaling in interferon, people report less breathlessness. So here in the blue line is how many people reporting how breathless they are while they had COVID-19 versus people who inhaled a placebo. And you can see that people who inhaled a placebo had greater amount of breathlessness than people who actually got the drug. Then they also looked at people who were recovering, and people who got the drug recovered better. That's why it's over here on this side. They got discharged from the hospital faster, and they reported having a better outcome than people who only got placebo. So this was only in 100 people, so more people are now being studied to see whether or not this actually works for people with early COVID. So in summary, antivirals are being developed for SARS-CoV-2. Antibody-based therapies, such as passive immunization that we talked about, are promising, and some have gotten these emergency use authorizations for people who are at high risk for progression, but they're only currently available by intravenous, but new versions are coming and going to be tested to see if they work. Unfortunately, these monoclonal antibodies can be thwarted by viral evolution, and we're already seeing that happen, and we're going to have to stay on top of that to make sure that our treatments keep up with the mutation of the virus. Other things like serine protease inhibitors, viral polymerase inhibitors, and interferon, and others are currently in trials to try to get out to the best therapies possible for people who have COVID-19. And I'd just like to acknowledge there is a trial going on at UCSD and actually all across the world called ACTIV-2. It's part of the US government's response to COVID, also known as formally as Operation Warp Speed. And it's testing many of the therapies that I just showed today. And our website is down here called riseabovecovid.org if anybody gets a chance to look at it. And then Dr. Sheldon gave me some slides, and Croy was able to give me some slides as well for some of these agents. So I'm going to stop there and turn it over to Dr. Morris, Sheldon Morris.
All right, thank you. Here we go. I'll share my screen then, and thank you for having me speak today. It's a real pleasure to be with my colleagues here today. I titled my talk COVID-19 Notes from the Underground by the Numbers. And Notes from the Underground is actually a novel by Fyodor Dostoevsky, who's famous for writing Crime and Punishment. He's a Russian novelist from the Tsarist times. And his thesis was that part of life was experiencing suffering. And so it struck me that we've experienced a lot of suffering in the past year or more, and as a nation in all over the world because of COVID-19. So in his terms, we really are experiencing life in a big way. I also said by the numbers because by the end of this talk, I want you all to be able to do simple calculations and be able to make some decision making on your own. Because one of the things I did do, I mainly do clinical trials now, but I did train in doing, infectious disease epidemiology, and we have some wonderful modelers here at UC San Diego that have created very intricate and excellent models for COVID-19. But it all comes down to you have these buckets of where people are, and if they are in the first bucket, the S bucket, they are susceptible. They're people that can get infected with whatever the infection is. And in this case, with this SARS-CoV-2 coming out, a brand new virus, no humans have had this, almost everybody is in the S bucket. Then you have people that get infected, and they're the ones that have all the morbidity and mortality related to the disease. And then you have a group R, I like to call them removed, because they can be either because they've recovered and become immune from to the infection. They may have died or perished from their infection and no longer able to get infected, obviously. And there are people that could be vaccinated who've also achieved immunity. And they can move between these different compartments. But for the most part, you want to put as many people into that R bucket through vaccination and safe means so that you can remove the number of people that could be infectious. And the manner that how quickly people move is how infectious the actual virus is, and how much people are exposed. And that's why we use those interventions such as wearing a mask and keeping our distance to reduce the chance of getting the infection. I think you saw this also with Dr. Schooley's slides, but it always strikes me when I just do again a bit of the math, that when you think that just by the case reports with this most latest number, almost 10% of people in the US have had COVID-19. And when you think of how many people have died, about 1.7 out of 1,000 people, that's almost 1 in 500 people have died of COVID-19. And if you think about that, it's like somebody in your neighborhood, on average would have died, and every neighborhood in the United States where somebody has happened. It's just mind-boggling statistic. I took that population from the ticker from the Census Bureau that ticks up rather than the most recent census. But we know that it doesn't affect everybody uniformly, right? We know that people that are older are much more likely to die. And so you see a dramatic increase in deaths over the age of 65. But and also hospitalizations are much higher in those that are older. But that's actually not where most people are infected. You see the bulk of people that are infected tend to be the people that are in the middle age groups, 18 to 64. These are all relative, chances of infection related to the pediatric group of 5 to 17. Now, I wanted to hone down to San Diego. I know some of you probably are from San Diego, but I want to use this as a base case to understand the epidemic more and how we think about this. In San Diego, we've seen, again, the same thing as the rest of the country, sort of this leveling off of number of cases. But we, as a few days ago, the county was reporting 273 cases, 708. And maybe many of you do look at this website from the county because it is very informative. And if you look at, what I put on the inset of that graph, you'll see that when who actually had the case, infections that reported to the county, the highest rate was in the age of 20 to 29. So the bulk of people that have the COVID are not necessarily, the people that are over 65 in those highest risk groups, but they are, of course, the ones at most risk that we needed to protect. But this will come back in later slides and it's an important point. Now, here's sort of the epidemic in San Diego. We started off with our first public health order back in March 12th, 2020. And then it grumbled along. And as you can see, we've had these number of spikes. And then we had this new sort of tier system of deciding about interventions and what kind of public health interventions needed to be done. That started in September, and we immediately entered into what's called the red tier here in California. And then quickly in the late fall, winter, we had the huge spike there, and that became the purple tier. And you've probably all been aware of the implications of that, where we have to, not go to restaurants, et cetera. Eventually, that has changed, and more recently, we've had some rapid declines in case rates, and other factors that have led to us being able to be more liberal with the people being able to have higher capacity at restaurants and bars, et cetera. Although there's some concern about people getting back and mixing for potential, second waves or third waves that we've seen in some other parts of the country already. This is just the last, about month or so, because it really shows you, because you can't see how low it is there, right? So this is the number of cases that are being reported per day in San Diego, and it bounces around depending on, probably different factors, such as, the day people are open to report. But, we've come down to this level where we're at 200 to 300 in the last few days, or in April here. So that's been a remarkable reduction compared to those peaks way back. Now it seems in the middle of the holiday months, in December and January. So we've made a great deal of progress. But I think from my perspective, I was trying to think, well, what's going to happen next? Are we expecting another big bump? Are we doing a good job of controlling this? What's going to happen? So I wanted to look more into those numbers. The other part, that is an indicator of how well we're doing is what percentage of people that are testing are actually positive. And this is usually from the viral testing, get that nose swab. And again, we've seen this dramatic improvement here in the past month, where we're down to 2% or less in some cases, on some days, that of people that are testing in the county that are positive for the SARS-CoV-2. So that's again, it looks very good, doesn't it? But the question is, will that last? And that's certainly why, there's been a lot of talk to say, continue with your mask wearing and all your precautions as much as you can. some of the really good things we're doing. In at least in San Diego, we're doing a pretty good job of vaccinations. I think there's been a lot of efforts through UC San Diego to help start up the super sites, et cetera, and then other healthcare providers in the county that have stepped up. And right now, there, just a few days ago here, we're saying that there's almost 720,000 people that have got at least one dose of the vaccine, if it's a 2-dose vaccine, and there's a 1.181 million people here, or 44% of their county population that has got at least one shot. And that's important because that one of the slides that came from Dr. Schooley you saw is from the data from the Moderna vaccine, where you really saw that people were responding to vaccine at day 12. So even though there's this 2-shot regimen, there appears to be some separation of the data points very early on after the first shot. So there probably is some immunity. Doesn't mean you should go with just having one shot, but it does mean that the immunity is starting very early on for these people, and many of these people may have levels of immunity. Although you have to go with the indication for how it was approved, and that still should be the 2 shots. Of course, some countries are having to consider going with just one shot for everybody because they have scarcity of vaccines. We have overabundance of vaccines well, I wouldn't say overabundance, but we are pretty well situated compared to other countries in the world. The other day I was seeing that Japan has only had, less than 2% of people vaccinated in total. Now, this is the back of the envelope kind of calculation. I think we still call that, or at least I do. So at the beginning, they were thinking that to gain herd immunity, that means the amount of people that need to be in that R group, or that removed group through vaccination or having infection, to start to quell the epidemic. A big factor that drives that, though, is the infectivity of the virus. And so when we get these new variants that have come on, how that impacts is, well, one, you start seeing those cases again because it's spreading faster, but it also means you need higher rates of herd immunity. So even though it said 70%, we're probably more towards 80% or more. It's hard to say where we're at with the new variants, depending on how prevalent those are in the community. But then I wanted to go and try to actually figure out where are we at in terms of achieving herd immunity. And I did sort of my more conservative estimate of this by looking at how many people have got both or complete vaccination, adding that to the number of reported cases. Another fact that we haven't really covered as much is that there's about a 10% chance of reinfection in some studies where they show people that have had previous COVID-19 were able to get reinfected. And similarly, depends on the vaccine, but I was kind of, estimating that about 10% of people who have vaccinations could potentially get infected. So that sort of discounted the overall number of people in the R group by about 10%. So, and I didn't necessarily try to adjust because I don't want to get too fancy, because I want you guys to be able to do this at home, is that, there may be some overlap. Some people that have had COVID-19 are also getting vaccinated, so they are counted kind of twice in that calculation. Also, at the rate of about, say, 200 a day and a 10-day window for clearance, because in clinical practice, when we see our patients, we're saying, well, 10 days from the day of your symptoms is when we can start talking about, having you go out of quarantine so that you're no longer infectious. Because as you saw that diagram, a virus really clears over the last 7 to 10 days. And really it's the inflammation component that really drives some of the more severe symptoms. But in later phases, they may not longer be as infectious. So I said about 3,000 people may be infected at any given time here. Based on that, of course, that's pretty rough because that's hard to measure. But then you subtract that from the total population, you see how many people might still be susceptible. So in this scenario, we're looking at about 33% of people possibly are immune. And that is, only about halfway to our original goals, and quite a ways off if we have this variant come in. So it really means that we still have to continue to do all our prevention measures and vaccinate people as quickly as possible. In a more, sort of, I would say a little more realistic, I didn't go all the way to thinking that that you could have even more, in fact, people resistant. But in this scenario where you give the benefit to the single vaccine, if you say the single people that have had a single vaccine shot at least, plus the people who have had COVID, and this comes into play that there's not everybody gets reported because the number of people that have COVID-19 are often either symptomatic, and then of course because of our screening programs we pick up some of those asymptomatic people. But there are also, prevalence estimates where they've done studies where they tested people more sort of random sample ways and compared it to the case reports. And in some cities, the number of the prevalence seemed to be 10 times greater than what the case report was saying. More conservatively, I said about 40% of people they say are asymptomatic with their infection, so they're potentially not get tested. Of course, that some people are just getting screened even if they're asymptomatics, like we do in our return to learn protocol. That's why the whole idea why we want to test those people is to pick them out earlier and take them out of circulation so they can spread it. But say there is about 40% of people that are asymptomatic and are on top of the people that we know from our reporting. So this allows us to sort of adjust up our calculation of a number of people that might be resistant to infection at this given time to the current variants that are going forward. So that gets us closer to 55%. And if there's more asymptomatic people or people that we didn't really diagnose that are out in the community, this may be higher. So that gets us much closer to it. And some of the data you're seeing in terms of a reduction in cases do kind of correlate with us doing a pretty good job between vaccinations, adding to the people that have already had it, that we may be getting a much smaller pool of susceptibles. And those are probably being, more and more into the younger people that have not even had the opportunity to get vaccinated yet. And some of the newer outbreaks in the other states you're seeing, like such as Michigan, seem to be in those younger group that are getting it. Of course, they do have lower mortality. So the long-term goal, the short-term goal was we need to vaccinate people that are at high risk of having morbidity, mortality, and that's why we're trying to protect those that are most vulnerable. But at this stage of the game, we're really trying to get to everybody that is more in the reservoir of infection, and that includes, like as I pointed out, a lot of the people are sort of more in the middle age groups, and eventually, hopefully, getting to the pediatric group. That would be a huge breakthrough. If we want to get kids back to school, we probably have to start getting those vaccinations out there. Now, I also wanted to do the numbers on this J&J vaccine. You heard about that. There's this new concern about having this glutton disorder with, in particular, it appears women of premenopausal women, 6 cases of clotting out of 6.8 million. And it's not just your DVT or pulmonary embolism, which we can usually treat most people with, like with anticoagulants. This is something that also is associated with low platelets. So it's a much more serious type of clotting disorder. And of course, there's people that have died. And this is somewhat similar to what we heard from the AstraZeneca and concerns that came up from the EMA. But what does that tell us in terms of should you get this vaccine? And obviously it's on pause right now, but what they're probably thinking about is, what's the risk versus benefit of this vaccine? So if we just take it on average, and that's about 1 case per million that have had of the clotting. There was another case, I think, in the news today, so that might be 7, but I don't know how many, what the denominator is on that. So that's about the rate of this clotting disorder. But of course, if half of that, if it's only in women, then you're thinking, well, it's really 6 out of, 3,400,000. And if it's only within the certain age group, it could be even, half of that. So this could actually be more closer to 3 to 4 cases per million for the high risk group. So that's an important consideration. Then I try to think of this through, well, what you're counting, what's your risk? Your real risk is having, the worst risk is dying from COVID-19. And in San Diego, we went through and we showed you the numbers, so I can go back and do that. I back calculated what they're using as the population just through their numbers of percent of vaccination. So it came up sort of a number of what they're looking at is the population in San Diego at 2.7 million. And if we kind of crumble along at this current rate, which is about 200 cases a day, we don't know if that might spike, or maybe we're going to do a gob and it's going to go away. But if you put that into an annual rate, your risk on average would be about 2.7% over the next year. That's low rate. Remember, back in the beginning of the year, this would have been much higher if it had continued at that rate. But right now, we're kind of at this sort of lower rate of infections, and that obviously could change. But then what is your risk of death? So if you look at the number of deaths in San Diego and put that over the denominator of how many cases reported, you come up with about 1.3% risk of mortality in COVID. And of course, this is a changing number. We have these better therapies, and that's going to reduce that number. We also have different changes in the demographics, maybe who gets infected, and that might change it. But again, we're trying to get back of the envelope. Is this a safe thing? So if you multiply those out, it comes out with your risk of dying over the next year in COVID. Right now, at this moment, I would estimate something around 0.35 per 1,000. So that's about 400 times greater than that 0.88 per 1 million doses. So you got to say, well, that's that's pretty good. There's still some benefit versus risk overall. But when you start thinking of if this is really just in this one risk group of women, that could very well come down to maybe 100 times or less, especially as if the epidemic continues to peter out. So it's questionable whether women in that risk group, if that pans out of what happens with the J&J vaccine, they may have to be excluded from getting this vaccine. And that's similarly, if the AstraZeneca data looked the same, that would be it. But this is kind of how you would do the math if you wanted to figure out, is this worth the bang for its buck? And well, does it do more good than harm at a population level? But certainly the determinants may very well be determined by whether it's affecting a very special sort of demographic. I wanted to end, I know we're talking in a sort of a forum for stem cells, so I wanted to sort of highlight that there is a lot of funding. And I think, all across the country, funders have turned towards COVID-19 projects to help the cause. And CERN was no different. They had a special call for discovery on COVID-19, and I found about 20 projects. I couldn't even fit them all here on developing different therapies. I know that several people have been interested in giving mesenchymal stem cells for it. There's some people that are clearly in very much more discovery phase. One thing that we've been involved at Alpha Clinic, of course, has been the convalescent plasma. We'd heard about convalescent plasma. We have been recruiting, San Diego residents for the City of Hope study, and that's been just started in the last few months. So hopefully that will continue, and all these other efforts will continue. And with that, I am going to stop, and I thank you for listening. And I'm going to turn it back to Dr. Jameson and Schooley for their moderation of the questions.
Yes, thank you so much to all three of you for your rather erudite presentations, and really to provide really important insights into how this virus propagates itself and how we can protect ourselves from it. Before we turn to Dr. Schooley and let him answer and direct the questions, I did have a couple of questions for the three of you. One for Dr. Smith. You mentioned TMPRSS2, which is really stimulated by androgens. It's upregulated by the male hormone. And just wondering about camostat mesylate's effects and whether they're dependent on male or female. We know early on, at least, that it looked like the mortality rate was higher in men, and there was a suggestion that maybe because of TMPRSS2 upregulation, the setting of androgen expression, that may have been part of the pathophysiology. What are your thoughts on camostat mesylate? Is there anything to suggest this serine protease inhibitor would have more effect in men than in women?
We don't know yet. I mean, it's a good question. We've known for a long time that men do worse with this. It is better to be female. And perhaps some of this might be androgen related to TMPRSS, which is that protein that protease inhibitor is working on, but we don't know yet. But I do know that in all the chemostat studies, they're looking very closely at the sex breakdown between men and women. The other one that's very interesting along those lines is the NK cells, which are immune cells in our body. Those also have differences between sexes, and that some people are predicting that that's one of the reasons also why men don't do as well as women with COVID-19.
There's also a KIR haplotype, a killer inhibitory receptor haplotype that determines how effective your NK cells are. Is there any suggestion, and I say this as a former bone marrow transplanter, that there's a specific KIR haplotype that would protect against COVID? Has anybody looked into that by whole genome sequencing or by other means?
People are absolutely looking into it. So Galit Alter is running a whole consortium to look at different KIR haplotypes.
Mm-hmm. And just a final question, you have been involved in stem cell thoughts about how to target COVID and the massive cytokine storm that occurs in some patients, and trying to predict how we can use stem cell biology to understand not just the immune response, but the activity of this virus in specific tissues. How have you been tackling this, considering this is the Sanford Stem Cell Clinical Center and Stem Cell Program closer look? Can you think of stem cell features that we can think about to tackle the virus? Any kind of stem cell approaches? What are your thoughts?
Yeah. So stem cells are, magical little creatures that have lots of special properties, and some of them could be very useful for COVID-19. And two different things that people are looking at. One is their anti-inflammatory properties. Those seem to be very important and could really turn the tide in someone, let's say, who is headed down towards that moderate, severe disease pathway for COVID-19. So I know that there are groups looking at that. Another very interesting one is an application that I just put in for a grant looking at stem cells, is to take progenitor cells, so stem cells, and package them with antivirals. Mm-hmm. And then those little stem cells go to the place where the infection is, because they have those properties to do so, and then deliver those antiviral payloads at the site where they're supposed to be. So it gives us a more targeted way to get the antiviral at the site of infection.
Very clever, as usual. So I hope that gets funded. Certainly we should talk more about that for the Sanford Center and partnering with you. The question I have for Dr. Schooley has to do with antiviral deaminase activation and mutation of the SARS-CoV-2 virus itself at the position that Davey was talking about. There was a paper that came out of Italy in Scientific Advances suggesting that both APOBEC and ADAR enzymes could actually mutate the virus. And there were suggestions of that by RNA sequencing. What mechanisms do you think are really fundamentally important for really leading to all these viral strains, whether it's the UK variant or, whether it's the South African variant? What do you think is the main driver of the mutation rates, and exactly where we're seeing the mutations in the spike protein that Davey alluded to?
Yeah, I can't tell you exactly why we're seeing them in those particular locations. At this point, empirically, we observe the mutations, and then most of the time when the mutations appear in the population, when you start doing in vitro studies, you'll find, if you have the right cell line, that they have a bit of an advantage for the virus in human cells, and they push forward. I'm a little bit of a simple guy, and think that a lot of what goes on with RNA viruses is they copy themselves sloppily, and the ones that help the virus are ones that are more likely to move forward into new generations of viruses, and those that don't are more likely to be a dead end. As Davey said, this virus is one that has is a little bit less, is a little bit more certain about what it wants to copy, because it has a little check mechanism. After it copies as it's copying its RNA, it checks to see what bases are being added, and very few other RNA viruses do that. Which is why it's much less variable than, for example, influenza, hepatitis C in particular, or HIV. Despite that, we have a lot of variation already, but that's what happens when you give a virus hundreds of millions of opportunities to replicate hundreds of millions of times in each of the hundreds of millions of people who have the virus. This virus has done a lot of experimentation, and that's one of the reasons it's vital we shut it down with vaccines and our public health interventions. No more shots on goal.
So speaking of shots on goal, literally shots, what are your thoughts, having led the Return to Learn program and global initiatives that will help to protect others from us and us from them on a booster? What are your thoughts, considering that RNA therapeutic based vaccines can be made fairly quickly?
We're going to need them. And the two things that will be driving it are how fast immunity decays. Coronavirus immunities is kind of a general phenomenon, don't last as long as immune responses to a number of other viral infections for reasons we don't understand. And with this particular virus, we have the variation we've been talking about. So to the extent that we see immune decay over time, and to the extent that we see viral variation, we'll have to be revaccinated. I would not be at all surprised to see us have to be revaccinated every year or two. It might turn out that people who are younger, like Dr. Smith, would need to be vaccinated every year, and people who are older, like me, might have to be vaccinated every 2 or 3 hours. But it'll depend very much, I think, on what we see over the next 6 months or so. The president of Moderna today speculated that it would need to be yearly, but I think it's too early to know for sure.
And that was my third question, is really, I'm a hematologist, so I look after patients with blood cancers who are long-term persisters and, or as Sheldon alluded to, are at increased risk for reinfection with the new strains. What are your thoughts about checking for antiviral, not just humoral or antibody-mediated immunity, but T-cell immunity, as the Leukemia Lymphoma Society is doing through their patient registry? Is this something that we should take on as initiatives here at UC San Diego and further afield?
It's something we need to understand. I mean, I have a patient that contacted me who receives rituximab for an autoimmune disease, and I helped her get vaccinated with one of the mRNA vaccines as far away from her quarterly infusions as possible. And when she finished getting vaccinated, I suggested that she at least get an anti-spike antibody test, and her primary care provider said, well, the CDC said you shouldn't do that. And after saying, but that's to the general population, I'd like to know whether she made any antibodies at all. And she didn't. So there are people who, despite being vaccinated, will still be at risk and will need to continue to take the public health precautions that has kept them from getting infected so far, both because they're still going to be at risk with the vaccine, and also because if they do get infected, they will be more likely not to do as well. Your point about T-cell immunity is a very good one. I believe in T-cell immunity. We don't generally measure it as frequently as we should because it's harder to measure in a reproducible way than to measure neutralizing antibodies. But I think they're very important, particularly in preventing severe disease and helping people recover from an infection. We don't yet know what the correlates of immunity are. How many T cells, how broad should the response be in terms of the epitope coverage, or the if you start looking at which cytokines get elaborated, the distribution of T cell immunity that is produced. And doing those studies will help us begin to get a better understanding of what we should be looking at and being able to give people advice about whether they're protected, and also to help us know when we should start thinking about revaccinating people. Right now, all we can do is wait to see what the tempo of new reinfection is, look at those who are getting reinfected and try to do correlates, but it's very much a work in progress.
Right. So I just have two questions for Dr. Morris before turning it back to you, Dr. Schooley, for the questions in the chat. These are questions that have been asked prior to this session in anticipation of this session. So Dr. Morris, you mentioned a lot about herd immunity and how we can model basically the spread of the virus using your, epidemiological standards for doing that. But how do we promote model behavior, so to speak? A lot of this is behavioral. And, you were saying that, provided people are vaccinated, we're going to be in pretty good shape. But how do you change the paradigm so people aren't so afraid of the vaccine when we see that, the 1 in a million cases that Davey was talking about had unfortunately adverse events from a type of vaccine where you get cavernous sinus thrombosis. You get a kind of clotting that looks almost like heparin-induced thrombocytopenia with antiplatelet factor 4 antibodies. How would you tackle that as an epidemiologist that has a background in public health?
Well, it's a lot about messaging that, and that's something that we didn't really go over or talk about as much, is that we recognize there's disparities in who's getting COVID-19. We have, by regions of the country, by race, ethnicity, by socioeconomic status, and so and each of those has different challenges. First thing is you should always be honest. You need to let people know what the real deal is, and never try to be dishonest in saying what is this really related to vaccine? Well, if it is, we should let people know that, and let people be able to make their own decisions around getting which vaccine they want. I mean, you do have to try to promote the vaccine in a positive way, and explain and have representatives and exposure in all those parts of a city, or especially getting out to places where there's a lot of resistance to vaccination. When you have people that are say anti-vaccine, you've got to group them in different ways. There's some people that are so strongly anti-vaccine that you'll never convince those people. And so you can't really spend a lot of time there. You need to get the people in the middle who are doubters to be better informed and make better decisions around getting vaccination for them and their families. And so we need to get out to those communities, have good representation, and I think that we've generally been trying to do that, and it's been quite a good job at UCSD, where they've had the vaccine sort of mobile centers go out. I mean, this is the kind of thing we have to be creative, and it's not the same model that we would have for routine healthcare, where you have to go find a doctor, make an appointment, wait all day in the office. We need to get out to those communities, make it available in the pharmacies and places that they are more used to and trust. So I think we're doing a lot of those things, and we're seeing those successes. At some point, we're going to reach a point where we have a lot of people that, the only people left will be those people that are very resistant to vaccines. And I guess the hope is that that point will be when we reach herd immunity already, and we've reduced the epidemic significantly.
Right. And just my final question to you before turning it back to Dr. Schooley for the questions in the chat. I had a question as the Deputy Director of the Alpha Stem Cell Clinic here, and what you showed as your slide for the California Institute for Regenerative Medicine approaches to targeting SARS-CoV-2. You've been running this passive immunity program so that we can link the Alpha clinics that serve 20 million people in California. What do you see beyond that for accessibility? You were just alluding to their underrepresented minority populations, people that work in rural areas, certain plans to expand the Alpha clinics and have community care centers of excellence. How can we interdigitate the programs that Chip has really championed here? Davey has made sure that we have the most effective treatments possible. How do we get these to the outlying communities using some of the $5.5 billion in funding that was just approved in the state for stem cell research? How would you suggest that be done, considering the epidemiological strategies that you've outlined?
Well, I mean, each community is different, right? So you have, it's going to be, what is the health system that's going to be most efficient in each region? So sometimes that means, something like the health department, but, if the health department is a very small department that is poorly funded, they're not going to be able to handle a lot of that. So maybe it's the the university or the health or the insurer or the hospital or the community health group that needs to be engaged in providing, standards of care. And so obviously having good guidelines are really important, having national guidelines on treatment and implementing those through those systems. With things that are more complex, if we are getting to cellular therapy, stem cell therapies, you're going to need centers that are very good at doing those things. And that's going to be a little more challenging to implement into smaller communities and hospitals that don't have capacity for that. So there has to be the capacity to handle these more sort of complex therapies. So ideally, we have strategies that are simpler, easier to be implemented, anywhere in the United States, in the world, because there are a lot of challenges that are going to continue. And if we're talking about the variants, I mean, there's so much potential for more variants from the rest of the world unless we can get the whole world vaccinated and the whole epidemic to drop.
Well, thanks so much for that global perspective. Speaking of global perspective, back to Dr. Schooley to answer the 11 questions in the chat or address them together with this group.
Thanks very much, Kat. Let me just pass the first couple of related questions on to Dr. Smith related to vaccination, whether any of the efficacy correlates go with the severity of your local or systemic response, and whether or not the level of antibodies developed in natural infection correlates with the severity of the disease.
Yeah, those are good questions. So I got my second shot, and after my second shot, I passed out for a day and a half. And it really annoyed Asher a lot, but I survived. And the good news about that strong reaction was that it probably meant that I was making pretty good immune responses, including a neutralizing antibody, which seems to be one of the possible suspects for that immune correlate that you were talking about. And the same thing goes is that people who have, unfortunately, severe cases of COVID-19 and survive, the silver lining is that they usually mount a really strong response as well and are less likely, it seems, to get reinfected. However, everybody's different and everybody's immune responses are different, and including how long that immunity lasts.
And let's stay with you, Davey, while we're on it. What's your take on interaction between COVID-19 and HIV in terms of bidirectional interactions?
Yeah, so there's been lots of, at the very beginning of the epidemic, being an HIV doctor, I was very worried about my patients in COVID-19, and I guess still am. And what we've seen is they do carry an increased risk for COVID-19, especially if they are not on their HIV medications, or their HIV medications are not working for them. But people who are on their medication and doing well, their risk seems to be a lot less. However, when people have HIV, they also have oftentimes other what we call inflammation-related comorbidities, such as heart disease, diabetes, neurovascular disease, etc. And all of those comorbidities are also a risk for COVID-19. So it might not always just be the HIV that's causing the problem. It's the HIV causing the comorbidity that then causes worsening of COVID-19 disease.
And let me turn to Sheldon for a minute. How do you think this 70–80% figure that's often tossed about for COVID compares to other diseases that require high amounts of herd immunity? Can you create a hierarchy among the ones we know about?
Sure. I mean, there are certain things that are much more infectious, and I mean, those that are aerosolized are those the type of infection that when you have a virus that's aerosolized, like measles is a classic example, very infectious, aerosolized, and to get immunity and is very hard. So we know we've been vaccinating people across the world trying to eliminate polio, measles, these common childhood illness, and we haven't done it yet. It's that hard. It has to be closer to 100% almost to get that, extinguish those and declare those viruses to be eradicated. Now, this kind of sits in the middle there, right? So this is kind of aerosolized, but compared to measles, chickenpox, it's not quite as infectious as that. And then it's probably sitting above though things like flu, colds, even a bit more. And then, common bacterial infections like strep throat would be much lower. Now, we don't have vaccines for those things, but we do have for some bacterial things. And so we are working, that's why you get so many vaccines as a kid, because we can really prevent a lot of infections. But, we're far from eradicating most infectious diseases. Of course, we thought we were doing great with smallpox, which is, again, a very infectious thing, but we, was able to completely eradicate. And part of that is because smallpox has no other reservoir other humans. And so that's another whole nother issue, is if there's an alternative reservoir for these things, such as we talk about bats as a possible source of SARS-CoV-2, that's going to be really hard to totally eradicate this coronaviruses ever. And that's why some people that are working on vaccines that are pan-coronavirus are really a longer term, goal, because, we're going to see more coronaviruses come out of the animal world, and we can't, completely control them.
So along those lines, there's a question about whether or not this virus is a pre-indicator of worse things to come. And I think what we've seen over the last 20 or 30 years is that there are a lot of things going on in the world that are making things that have been naturally occurring for hundreds of thousands of years have a larger impact. We have much more interaction globally. This virus, as I mentioned, was initially found around one food market in China, and within a couple of months it was around the world. Boeing has done that for us. We have a number of changes in climate that push vectors that normally are found in more concentrated areas of the world into other parts of the world. Go into, for example, vectors that used to be found mainly in warmer climates are now found further north. And so pathogens are finding their way into populations of humans who've never seen them before. When we degrade the environment and people have to forage for food, people come in contact with animals they don't normally come in contact with, that carry things like these coronaviruses that spill over into us. So a lot of the things that are going on around us are things that are going to continue to cause these events to occur. It's going to be very important for us to be more prepared systematically for these infections going forward than to kind of stumble into each one and act like it's never happened before. So this is a bit of a wake-up call about where we are headed. It's not going to be an isolated event. There's a question here about whether or not the risk of someone being vaccinated, what's their risk of transmitting the virus to other people? Sheldon, do you want to take that one on?
Sure. I mean, I think it's pretty low. I mean, obviously, if somebody's been vaccinated, they'd have to be in this group of people that can get infected. So there'd have to be failing the vaccine, or, as we don't really know how long, their immune status lasts with vaccines or from infection itself. So they might be able to get infected in the future, 6 months, 12 months, we don't know yet. So they'd have to first get exposed. Right now, we have very low rates. If you got vaccinated, you'd have to first fall into the group that the vaccine did not take hold in. You'd have to be exposed and get infected, which right now it has declined significantly. So that's biggest, your largest factor. Once you're vaccinated and you get infected, well, you're probably you are at risk. Then you'd probably be, you might have depending on if you've developed any immunity, you might have different viral load, and the viral load seems to correlate with symptoms and amount, but more importantly, maybe how much antibodies you make and how immune status, how good your immune status is going forward. So, you would be infectious to that group, but up front, you've protected, your family by getting vaccinated. And, if you want to take additional precautions, continue to wear your mask and doing your public health interventions in terms of avoiding, large crowded, especially indoor spaces with other people. So So, but overall, we've loosened up those guidelines. We know that vaccine people are protected, and we're saying that they can travel across the country using their masks and not have to get tested and quarantined on either end. So we have good faith that they're very unlikely to get infected and therefore pass it on to their children.
So Dr. Berg has a couple of really very interesting questions here. One is about whether or not we are anywhere near being able to come up with a nasal spray that would prevent infection that might be used prophylactically. And the other is about the pathogenesis of these clotting defects. I'm pessimistic about topical nasal spray being able to be as effective as you'd like it to be, because I think that much of the transmission of this virus occurs with small aerosol particles that are being inhaled deeply into the lungs. Yes, the virus does grow in the nose. There are ACE2 receptors there. But I think the pathogenesis of this disease involves a much broader challenge than just in the nasal mucosa with downward spread. The clotting disorder is something that we're just beginning to learn about. There is a finding that about, the people who have this may be thrombocytopenic. So these are people with thrombocytopenic thrombosis. Sometimes you see that with unusual responses to heparin in people who have antibodies, anti-PF4 antibodies. And the 6 women who were investigated are being investigated with the vaccine, the Johnson & Johnson vaccine had those antibodies. About 4% of the population have those antibodies, but obviously most people who have those antibodies don't get this complication because we're not having 4% of people develop this. It's 1 in a million. So what role those play, we don't completely know. It does raise questions about whether heparin is the treatment of choice for people who develop this. And then finally, I would say adenoviruses themselves are not really known to be causes of or associated with cavernous sinus thrombosis, natural infection with adenoviruses. We do see that more often in people who have infections of the nasal sinuses and periorbital infections, often bacterial infections in these areas, draining back into these sinuses. We know that, as I said a minute ago, the virus does replicate in the nasal mucosa and it follows the olfactory bulb backward, which is why people lose smell. But why this would happen after a vaccine, unless there is some unusual concatenation of these people having to be just having been vaccinated about the time they're becoming infected and having some local more exuberant response. Right now it's a lot of hand waving, and I hope that we understand better, because it'll give us a better idea about whether to continue using the vaccine, and if so, whether we should be targeting it. How safe is the vaccine for pregnant women? Pregnant women were not included in the initial trials, but they many pregnant women have been vaccinated. There's a registry looking at this, and there's no evidence, at least with the mRNA vaccines, that there is any more danger with these vaccines than in the general population. We do know that pregnant women can be more likely to have more severe disease, and so people who are pregnant should talk to their obstetricians and gynecologists. But in general, my feeling is that women should be vaccinated because of the complications. 2 last questions, because we're running over here. One is about long COVID. How long will long COVID last, Davey?
I don't know, but all of the trials that I know of in terms of antivirals are looking at this long COVID question. So it could be up to almost a third of people who get COVID. It's probably less than that. There's a little bit of selection bias, but a good number of people are having these symptoms of COVID that seem to persist for quite a while. And the big question that we have in terms of antiviral treatment is if we nip it in the bud early, can we get rid of those long COVID symptoms? And we just don't know. Part of that is also we don't really know what is the cause of those long COVID symptoms. Is it residual inflammation? What is it? And those are things that still have to be figured out.
And John has asked a question about whether the delivery with stem cell progenitors delivering antiviral therapies are underway. Has anybody stolen your idea and run with it?
Not that I know of. If people want to do it, just send me the answer, but we're still working on it.
And then the last comment here was from someone who knew a man who had stage 3 Hodgkin's lymphoma, got COVID in the UK, 4 months later was much better. Is there any thought that some induction of innate immunity or some other immune aberration could lead to a clinical response to people with lymphoma? Davey, any hand waving about the immunology of that?
Yeah, no, I don't really know. It's very interesting. I mean, your case that you talked about as well with B cell defects, we do see people have very persistent infections in people who have Hodgkin's or other B cell abnormalities that might be at play. The one thing that I would have to say, here's the thing that I want to end on. We are all in this world together, and there are some of us who are the vaccine's not going to work for, like people like your patient that had the B cell issue. And to protect them, we need to get vaccinated so that we don't spread it to them when it happens. And that's the message I think that I would really like people to understand, is that maybe the vaccine isn't always just for us, it's for your neighbor and your loved one.
And with that, I think we're out of time. There are a couple of questions left over, but I think we should respect your time. And let me turn it back over to Dr. Jameson.
Well, thank you so much, Dr. Schooley, Dr. Smith, and Dr. Morris. I think we covered so many aspects of COVID that really haven't been presented in one forum, at least that I've heard in a long time. So this is extremely informative. Thank you so much. You know, I just wanted to make a comment in terms of the stem cell biology of COVID, bringing it back to the stem cell seminar series that this is. There are platelet progenitors that are actually made in the lung. And there's a stem cell fight or flight response that is elicited in response to major infections, and most likely in the case of COVID, that could lead to mobilization of those stem cells to sites, as you were alluding to, Dr. Schooley, for the cavernous sinus thrombosis. So I think we really need to understand a lot more about platelet biogenesis when it comes to this particular virus. But just in general, it's so clear we just have to predict and prevent COVID propagation. And whether you're doing the really complicated mathematical modeling that Dr. Morris suggested, or really coming up with massive vaccination programs, as you have, Dr. Schooley, and testing programs, and Davey, as you mentioned, really it's our collective responsibility to protect each other from a virus that really came from how we've become accustomed to traveling around the world and really not thinking about what we're spreading as we do it. So Dr. Schooley, I think that's the key point. And Davey, you know, it's really about caring about each other and getting back to our humanity, as I heard you say on TV not too long ago, and being compassionate. So thank you so much for your time. You'll see that a lot of people will have questions after this when they watch this on UCTV or YouTube. And I hope we can send you these questions from the Sanford Stem Cell Clinical Center and Stem Cell Program. We'll be able to make them available to you. Thank you so much for your time.